first speaker is Tom Forbes, who is asked to tell us why and where he is using closed cell stents. Tom.
Thanks, Mark. Let me see. Here's my disclosure. So I'm going to talk about bare metal stents and that are able to reach adult size. I'm not going to get into the coronary areas or the renal stents or the peripherals. And so part of the issues, what I love about closed cell stents is that there's really a great variety of them. You have the standard Palmaz stent, the Sigma Hinge Genesis XD stent. This is just open cell stent, which Jack's going to talk about shortly. It's not a closed cell, but just a comparison. And this is the Cheatham Platinum stent that we hopefully in the United States will be able to use this here within the next year or so. Here's a closed cell stent. One of the favorable properties of adding Sigma hinges into the closed cell stents relates to the flexion moments. You can literally turn the Genesis stent on a dime and be able to put it through very small sheaths. And this is the flexion moment looking at it in comparison to obviously the standard historical Palmaz 308 stent and the other stents. Even the open cell stents, the Genesis stent still has a better flexion moment than the open cell stents. Another reason why I like the closed cell stents relates to the profile. You can see here that this is the Cheatham Platinum stent, the Palmaz 10 series stent, the Genesis XD, and the EV3, the Intertherapeutics Mega and Maxi stents. And the introduction of the Sigma hinges allows this closed cell stent type to actually deliver through sheaths that are 2 to 3, sometimes 4 times smaller than the other counterpart stents, either into the open cell stents or the larger closed cell stents. The profile of the Genesis stent, you can actually get through a 6 French sheath, so placement in an infant is reasonable for pulmonary arterial issues. And then we're looking at radial strength testing of the closed cell stents versus the open cell stents. And why I prefer it, not that it's really been much of an issue. So these are the old intertherapeutic stents, and what we noted is that at about 12 to 15 millimeters, we noticed stent recoil occurring, especially with coarctation of the aorta at that diameter. So we felt that 4 psi here was what was needed in order to accomplish the prevention of in-stent recoil. All of them pretty much stay above that, but certainly the closed cell stents do much better in regards to retaining their radial strength at larger diameters. And then again, related to the foreshortening properties of the stent, obviously the Palmaz old open cell stent, closed cell stent, shows the highest propensity for foreshortening. All these stents were loaded on the same balloons. These were not bib balloons. I contend that foreshortening at both 10 and 15 millimeters is really, actually 10 millimeters is really minimal for all stents. 15 millimeters is when we really start seeing foreshortening, but it relates more to balloon length than it is actually the stent itself. And really the open cell stents really hold up the best. But even with larger size balloon, I should say longer balloons at larger sizes, even the open cell stents could have significant foreshortening. So I think it's more important with regards to stent, when you choose a stent, that choose a balloon size at the length that's appropriate for the stent itself. Related to the profile of the closed cell stents, the Genesis XD, the balloon technology has actually exceeded our stent capabilities of being able to actually load them or crimp them onto the balloons themselves. And so what we're having to do with the Genesis XDs, stents in particular, is that when we put them on very low profile balloons, 5 and 6 millimeter balloons, we have to dog bone them at about 8.8 atmospheres in order to get them to stick onto the stents themselves. But we're still able to get them through a 6 French sheath. So where do I use certain closed cell stents? For the Genesis XD stents, I pretty much exclusively use them to treat pulmonary artery stenosis, especially in smaller infants. One of the problems with all closed cell stents, at least the current lengths of them, are a little bit too long. Even the Genesis XD 19 series stent sometimes can be a little long in regards to infants with proximal pulmonary stenosis. Treatment of coarctation of the aorta less than 50 kilograms, we use Genesis XD stents. Venous stenosis, almost exclusively we use Genesis XD stents. In regards to Palmaz 10 series stents, almost exclusively in the right ventricular pulmonary artery conduit stenosis is what we use them. And I don't know if anybody's had any experience, but we've not seen any fracture in these in our experience. And the Cheatham Platinum stent, when it becomes available, I would state we'd probably use it for treatment of coarctation of the aorta. We've loved this for that, bare metals at greater than 50 kilograms. And obviously a coarctation of the aorta if you're overlapping a vessel. I'll show you why. And one of the problems we've had with the Genesis stents, which I'd say is probably the Achilles heel of this stent, is fractures. They always fracture along the Sigma hinges. So really they come into 2 pieces here. We've never had embolization of piece except for conduit stenosis. RV to PA conduits, so we refused to put them in that circumstance. Of 35 of those required reintervention with the second stent placement, so for the vast majority of them actually remained open, but about 1/3 of them required a second stent placement due to in-stent restenosis. I'm not seeing any Palmaz 10 series fractures observed in the coarctation. And where do I absolutely avoid the use of certain closed cell stents? The Genesis XD stent in any RV to PA conduit. It'll explode. We've had shards go out into the RPA and LPA, pieces everywhere in the RV outflow tract and in the RV apex in one stent. So we pretty much avoid these at all costs, unless of an infants with acute homograft failure that you're really trying to just put a stent in it, but you can also get away with some of the renal or larger coronary stents in those particular circumstances. And the Palmaz 30, the 10 series and Cheatham Platinum and coarctation of the aorta in children less than 30 kilograms, I think just the size profile of those stents makes it difficult to use under those circumstances. And one of the things now that with the Conquest has come out with the new balloons, a 40-atmosphere balloon, what we've been able to do is really actually expand the cells of these stents off into side branches. So this is the Genesis XD, and you can actually dilate it up to 6 millimeters through it with a Conquest 40 balloon, which covers pretty much the majority of branch pulmonary stenosis. It would not cover the issues of coarctation of the aorta. The Palmaz 10 series stent, we've been able to dilate up to 10. And I spoke to John Cheatham and actually did some bench testing. The Cheatham Platinum stent can be dilated up to 12 millimeters, which pretty much would allow you to overlap branches in the coarctation if you had distal transverse aortic arch narrowing and you had to overlap the subclavian vertebral system. And one of the things I wanted to just show you in regards to the caution as far as using, and Mark's going to talk about covered stents, this is a case that happened not too long ago. And this is a Cheatham Platinum stent, but thankfully it was a bare metal stent. What happens is it embolize. So anywhere from 5 to 7%, but now the most recent experience we've had is around 3% of institutions are seeing embolization of stents. And when you use a covered stent as a primary treatment of coarctation of the aorta, you have to be cognizant about what the transverse and proximal descending aorta, I'm not talking transverse, but the thoracic and proximal descending aorta at the level of the diaphragm is with regards to the diameters. The Cheatham Platinum can get up to 26 millimeters covered. The Advanta can get up to around 22, 24. And we had one case, not our experience, but they sent to us through the CCIC where they had a covered stent that embolized into the mid-thoracic aorta, and they had to have surgically remove it. So if you have stent embolization with a covered stent for primary use for coarctation, at least be cognizant about what the size of the aorta is at the mid-thoracic and abdominal aorta is. Otherwise, we predominantly use the bare metal closed cell stents for coarctation. So in conclusion, there are many different flavors for closed cell stents that allow for differing patient demographics. Smaller profile, flexibility, we use the Genesis XD. Durability, if we have concerns like RV and PA conduits, Palmaz 10 series. MRI compatibility, differing lengths. Side vessel branch overlap, we tend to go with the CP stents. That's it. Thank you.
Thank you very much, Tom. His presentation is open for questions.
Thanks.
I think you were clear.
Oh. So not too many questions. So Jackie Kreitzer is going to discuss open cell stents.
Thank you. Good afternoon. Thanks very much for the organizers for inviting me. So my disclosures. So I'll cover some of the design features, although some were actually covered very nicely in the previous lecture, and ideal characteristics of stents and some of the common open cell designs we use in congenital heart disease, mostly in the US. Obviously, my experience is limited to that. And some examples of why and when we use open cell versus closed cell. So some of these performance attributes we know that vary whether a stent is open cell or closed cell. And these are characteristics that we need to look at. The circumferential stiffness and strength, some scaffolding properties, which means how much it covers. And the more coverage, the less likely supposedly to have new intima proliferation and restenosis. The conformability to a tortuous course, to a lesion, to the shape of the underlying lesion. Side branch preservation, that's a big issue for us. And the delivery profile, of course, in pediatrics is very important. and the flexibility, which, as you know, for a lot of the closed cell design stents, such as Palmas, obviously would have much less flexibility than an EV3 open cell. But we also don't know a lot about how those features do affect stent performance in congenital heart lesions. The ideal stent really doesn't exist. All these stents have some great features, but then they have some other drawbacks. It would be the lowest profile, of course, for us, with high trackability and flexibility. They can track the tortuous courses with sufficient radial strength, so they wouldn't have a lot of stent recoil, low rigidity, so it wouldn't fracture, and predictable minimal foreshortening, so you can predict what exactly it would cover when it's expanded at various dimensions. Prevention of tissue protrusion, so minimal new intimal proliferation, to have round edges so the balloon wouldn't burst, and to have the redilation capability so we can blow it up to adult size in the future. Of course, to be resistant to thrombus formation, to be compatible with MRI, to be seen easily on X-ray, and open cell ideally so that we can open the side branches. So of course, there's no stent with all those features. As you can see, and it was shown before, the closed cell, each cell has adjacent ring segments are connected at every possible junction. While in the closed cell, some of those connections are eliminated, and therefore the cells are typically much larger. There's less coverage, there's less metal covering, less scaffolding. And we know that a lot of the closed cell designs now have come up with some features to increase flexibility, such as in the Genesis. How much, whether it's open or closed cell, may not matter so much as the size of the cell with regards to the issue of neointimal proliferation. In general, the open cell design tends to have much larger cell size than the closed cell. And when open cell, the cells in the outer part of the curvature, for instance, will likely be much larger than in the inner part, and that may affect issues of neointimal proliferation and in-stent restenosis, which is an issue with some of our lesions. We know one of the biggest features, advantages of open cell is that you can open side branches, and you can, as demonstrated before, clearly make a hole in the stent for the side branch with the EV3 stents. So one of the most common ones in the US open cell that are used are the EV3, particularly the Max CLD, Mega, and the double strut. Mostly Maxi is what's used most commonly. And these that come in the various sizes listed above. Have minimal foreshortening, especially if it's expanded gradually. And this is a stent I have a little bit of experience, but it's small. These are small pre-mounted stents for small lesions. And then the Valio is also open cell, blind barred, and these are for small lesions, not adult size. Of course, the EV3 Protégé, there are self-expanding stents using the hybrids mostly, and those are open cell. And there are some others that we don't have much experience in the US. Some of the Andra stent, for instance, is a hybrid open and closed cell, and I think we're going to have some presentations on these on the abstract session today. So I look back at our experience at Children's in Pittsburgh of how many of these open cells have we have used there, and since we moved to a new hospital, 136 patients got stents, closed cell 85, so vast majority closed cells, but all 51 open cells, and most of them were Maxi LDs, and actually it was one Mega that I implanted by mistake. I thought it was the Maxi, they gave me the wrong stent, and I did not check. EV3 Protégés hybrid 7. And then 6 patients, and those were infants, small kids with the formula 418, and 1 patient with a Valio stent. And the reasons why, when looking back at the angiograms, you could sort of guess why I chose one thing or the other, mostly for curvature conformability, optimal size, because it happens sometimes, the formula 418, for instance, come in a 12 millimeter length, so that's really nice and short. And if you have a side branch coming up, you may choose a stent because of the options of what you have on the shelf. Conserve side branch jail, and then for the hybrids, the EV3s are Protégé are known to be excellent for that. So for curvature conformability, the 31 patients, 3 were for coarctations because there was curvature in the vessel. 18 patients were melodies, melody conduits that they were not very straight, and we had a hard time getting a Palmas out there. Most of the times, the AV3 goes first, and then the Palmas is actually to follow, so because the AV3s have too much stent recoil. So over 50% of those ended up with a Palmas in addition to the max CLD. SVC baffles, pulmonary arteries in 9. And then this is, for instance, an example of those Cook Formula 1 in a baby with Alagilles, very small pulmonary arteries, tetralogy, had an RV outflow tract patch, VSD left open, very blue, worsening liver disease. So we need to get this kid repaired and lower the RV pressure. So we ended dilating, didn't do anything to these pulmonary arteries, so we ended up stenting, and I did use the small Cook stents. And then later on in the OR, Victor Morel put a melody valve, which he had to fold because it was very long. You can see that the edges of the melody valve are folded down to make it smaller. And then came back and we redilated the melody valve, redilated the stents there. So for a small, the length of these stents is quite nice and short, but may not be dilatable more than 12 millimeters. Then with regards to concern for side branch, had a Fontan baffle, patient that had a stenosis, a failing Fontan with a fenestration, placed an EV3, and then you could open up the fenestration, and this fenestration stayed open already over a year post the procedure. So as known with the EV3s, you can make a nice open hole within the stent. Other side branches, high nominated SVC obstruction with a nominated vein coming in. Also, we could do that and open a hole through the side of the stent. Pulmonary arteries, that's very well known, and coarctation for subclavian, a subclavian artery coming off the area of the core. You can balloon dilate and open a hole. Pre-melody, sometimes it happens that you may have a short conduit, or you may have concerns that the stent may protrude into one of the branches. So choosing an open cell gives you obviously a little bit of the peace of mind that you can then go and open the side of the cell and open the branch. And this is what happened with this lady. She's an adult who had tetralogy pulmonary atresia, very abnormal pulmonary artery. She had had a bifurcating homograph, a 16 millimeter bifurcating homograph, had no central pulmonary arteries originally. And so these vessels were very tortuous and had a series of stents that were all EV3 because max CLD, because of the tortuosity. And then she came back for a melody valve and pre-stented with an EV3 that was moved forward, and so ended up jailing the right pulmonary artery. So following that, I have a series of balloon procedures to get through the side of the stent, open up the struts, and then with an atlas, all the way up to 16 millimeters, we got to open up really nicely. And it would have been a nightmare if I had used Palmas. And then we clearly, afterwards putting the melody, you could see that it's nice and open. There's really a big cell. You can see it in the image on the left-hand side that it's opened up. The cell it's essentially a big circle. Of some strut must have been fractured with the atlas. And then for the hybrids, obviously the advantage of these EV3 protégés, they're very, they conform to the arch nicely, and they can, if you needed to get through retrograde into the arch, which I haven't needed, but clearly something that happens, especially if you do a lot of hybrids, that gives you the option since it's an open cell. Also for conformability of vessels, sometimes EV3 max CLDs are the best. So in conclusion, open cell designs offer a lot of advantages that make them optimal for certain lesions in congenital heart disease. While they do have the lower rigidity and stiffness and strength, they recoil more, but they allow for side branch access, which is a big feature for us, and especially able to conform to tortuous courses. And how those design effects change how a stent does long term, very little about that. Thank you.
So any questions for Jackie on the open cell stents? I'll just start off, because of the difference in the open cell and closed cell, the profile, obviously, the open cell has a higher profile crimping when you're trying to crimp them on balloons. And do you do anything specific Do you size up on sheaths? Because, the closed cell, obviously, you can crimp tighter and everything.
Well, the EV3s, typically, most of the time, use a 12-French sheath.
Yeah.
So when you have big patients, that's not an issue. It becomes an issue when you're talking to a smaller kid. It was used all the same techniques. I don't know if you have any suggestions, but I will use any kind of the similar techniques and crimp it as much as we can, and then, with the sterile umbilical tape and all that stuff. But I don't find us that different. We use a 12-French sheath when it's an EV3 Maxi or Palmas.
Yeah, I think
pretty much is the same.
Yeah, I was just going to say, I think that what we learned a number of years ago with NewMed, as Tom pointed out, was an open cell design, but it was also made. It's not a laser cut, and it was 5.5 millimeters, and so you already had an 11 millimeter height, and so it acted like an open cell as far as going through it because it had wide areas. But we actually played around with making more open cell, or we called them chain length and flexible and all kinds of crazy things. But profiles increase, radial hoop strength goes down, etc. And I guess, I think it's important we look at the stents we put in so we see what their characteristics like. Some of the open cell that you showed, I always talk in terms of what is the ratio of where there is attachment and it's open, because it can be 1-to-1, it can be attached, not attached, attached, or attached, not attached, not attached, attached. So you have more open cells depending, and so you can go through, you can make it bigger as far as it would be less shortening, but it would be less strong.
Oh, yeah.
And so I think that's why the Cook Formula 410 is a combination of kind of closed but open, because it has the little ridges that connects each row. So I think that we can encourage our stent makers to try to come up with maybe different material, with maybe some of the open cells that will continue to add strength to them.
Strength.
And so I think hopefully people will do that.
Be good.
One other aspect is also that the discussion between open and closed cell technique will fade away, I think, by the use of high pressure balloons. Peter Ebert, now from Munich, has shown that he can open nearly any stent with a high pressure balloon. He blows open even closed cell stents going 18, 28 atmospheres. And we don't do it on the Palmases. We don't use them that much anymore in Europe. But all the other stents, the CP, the EV3, the Andra stent, if you can cross it.
Doesn't always open, because I've gone up to Conquest with no Palmas in a branch pomiatric. It was overlapping, and it doesn't give. So it doesn't always, especially Palmas.
How high? Well,
Close to 30.
I think it's the diameter too. The Conquest only goes to 12, and so sometimes you have to size up a little bit if you're going to really break them, because some of them will, as Jackie probably pointed out, they just don't, it depends on what the cell would normally go to, and you can kind of stretch, not break, but then if all of a sudden you put a 14 Atlas in there, it might have broke. We played around with this as well a lot early on, and sometimes you had to put a little larger balloon in than you normally would have wanted to explode, like Peter ended up, we did that back in '97 and showed you could break you could break any of the balloons, break any of the stents, but of course with the Bard products now you can, I think. I agree with your comment, but that's for side. The problem still is that the open cell are still not as strong, and they're not as some of the other things, and which we just saw with Eric's case, an open cell double covered stent that recoils.
Yeah, I recoil.
Okay. The next speaker is Joe Giovanni, and he's going to speak us about use of stents in hybrid procedures.
Way forward and backwards. Chairman, ladies and gentlemen, thank you very much. I would like to thank the course organisers for inviting me to participate at PICS yet again. I was unable to do it last year because of health reasons, but I'm delighted to be back. I have no disclosures that are applicable to this talk. As Jackie and Tom have shown, there are two extremes, which is the closed cell and the open cell. But as always, there's always a potential for compromise when you have two extremes, and that is the hybrid technology. In terms of the background, although we call it a stent, the original the description of was related to a mold that the dentist Charles Richard Stent used to hold a piece of skin in relation to a skin graft. So we were not talking about tubes. The first person who came with the idea of having a tube as a stent was Dr. Palmatz, who went to a Radio Shack to buy some copper wire and some soldering to prepare a very basic amateurish stent. But he clearly recognized that there was a need for improved technology, and he recruited an engineer who decided to employ the electrical discharge machinery to create the Palmatz stent. But these unfortunately have limitations. They can create closed cell technology, but not very advanced stents. However, we have two other methodologies, which is laser and photochemical etching, which can now produce so many different types and shapes. The combinations are absolutely infinite. There are at least over 150 types of stents, some of them for engineering or clinical reasons, but some of them just to overcome the copyright and the patent rules. And there are certainly more than 2,000 applications for stents, so there's a lot of interest in this. As has been mentioned, the closed cell, each cell is complete. With the open cell, these can be very, very variable. You can have 2 missing links or 3 missing links. The more missing links you have, the less, the more flexibility you have on the stent, but at the same time, you do compromise on this structure, and there's a higher risk of fracture. Plus, for the kind of problems that we're dealing with, we can't compare the lesions in congenital heart disease to the atheromatous disease that we see in peripheral artery disease or in coronary artery disease. So that is an important point. The hybrid is a bridge ideally on alternate struts. And we've seen some of these pictures, but you can see with the open cell design, there's the potential here for having major breaks in the coverage. So it depends really a lot on the lesion. And to some extent, there is also a little bit of a more risk of creating a fracture. In general, the closed cell design, the open cell design has the benefit of flexibility. The closed cell design has the benefit of being solid. The hybrid cell design combines the combination of the two good things about these two, which is it makes it solid but also flexible. And these are some examples, as has been shown, of the different types of stents. The flexibility is very, very important, particularly when you're dealing with very curved vessels. In this situation, using open cell design certainly has advantages. In terms of the properties, the engineers need to know where you're going to be using these devices so that they can adjust the length of the strut, the pitch of the strut itself, what kind of diameter you're likely to be using, and how many longitudinal connectors you're going to have. Obviously, the more longitudinal connectors you have, the less flexible, but also the more strong. And there are numerous types of designs. That will be a closed cell type of design. So for each 2 struts, there are 2 bridges. You have an open cell design, and then you have a combination of all these things. As I said, there are more than 150 type of designs. One of the problems with the closed cell design is if you try to overstretch it, then you're going to finish up with a ring rather than with a stent. That is less so of a problem with the open cell design. The hybrid is somewhere in between. But as I mentioned, when you go through a curve like that, you do open up gaps like this, and potentially can have sharp edges, which can actually cause problems with the vessel, such as dissection. One of the commonest stents that I do tend to use is this hybrid stent, which is the Andromet stent. It's made from chromium cobalt, it's laser cut, and there are alternate cells which are bridged and alternate ones which are not. So this is a true hybrid stent. There are other variations on this, and the formula stent, which is again very popular, and I think for very good reasons. There are, as John Cheetham mentioned in the discussion, these bridges between the two rings, which help it both in terms of the strength, but also in terms of the shortening. So in terms of the deployment of the formula stent, these are pre-mounted stents, which has the advantage of a low profile and also stability, and they very often inflate in a very sequential manner. So it starts at that point, then it forms a dog bone, and eventually it stays in position. So it's very, very, very good for placement in the appropriate position. Again, one of the benefits of the formula stent is that it doesn't shorten, and when we compare it with the Palmat stent of an equivalent diameter, you can see a marked shortening of the genesis compared to the formula stent. So this is undoubtedly something which is fairly new on the market and very good. In terms of the connectors, there are different engineering points about where you put the connectors and how you put them, whether they're going to be offset or in line, but we don't have time for that, but it will be on the lecture if someone wants to download it. And there are different design characteristics which Jackie mentioned in her talk, so we won't go through that either. So what kind of clinical features are we looking at in a stent? We want radial strength, obviously, particularly for certain types of lesions, which are very, very tough, including coarctations and pulmonary artery stents. Flexibility, and this is, again, depends on whether the vessel is going to be tortuous or curved. Recoil is very, very important, particularly for things like coarctation, as we've seen with the case which Eric showed earlier. Scaffolding, this is very, very important, but remember we have a different type of lesion compared to atherosclerotic disease. We don't want any kinking, but if you have too many open cells, you may potentially get kinking of the stent. So you do need to have at least 2 or 3, or not more than 2 or 3 cells between bridges. Think about positioning, and this is very, very important. We saw a stent earlier that moved down, and obviously fracture is very, very, very important. It's partly to do with the material, but it's also to do with the number of connectors. So hybrid features: less shortening than closed cells, more flexible than closed cells. There's no wedging or accordion effect, unlike open cells. They can be made from alloys, and they can be either laser cut or etched, and then once they're etched, they have to be rolled into a stent, because with etching you only can do on a plate. On the deployment of the stent, you can get irregularities at the site of the open cells. So the less open cells you have more of a smooth surface. However, there's always a little bit of bulging at the site of open cells, and this gives you a little bit more grip to prevent movement. And this is very good for both coarctation and also for RV outflow stenting. And when deployed in a curve, its shortening may be less than the nominal. So if the company says 10% shortening, that may not apply when you place these stents in a curved position. There are different types of materials. The ones that we generally tend to use are balloon expandable, so they can be stainless steel, such as the formula, the chromium cobalt, such as the Andra stent, and they can be either freestanding or pre-mounted. As I said, the formula one are pre-mounted. Bear in mind that if you're using that, make sure that you've got the right wire size and also the right shaft length. Some hybrid stents for congenital heart disease, the Andra stent, which is one of the ones that we commonly use in Europe. There are different versions. This is the thickest one and the one that goes to a largest diameter. So for RV outflow and for coarctation, I would recommend this. For pulmonary arteries, this is usually sufficient. There's the formula, which is very common, and for very small vessels such as RV outflow stent and Paolo's technology, the Liberté stent is also a hybrid design. Currently, there's only bare metal stents, but I'm sure for the hybrid versions, but I'm sure that there will be other covered stents using hybrid designs. So, in general, we tend to prefer hybrid stents for congenital heart disease because it gives you the benefits of closed and open. We tend to use them for RVOT, for pre-pulmonary valve and Fowler palliation in infants, pulmonary artery, main and branches. It's ideal for coarctation, but also good for venous stenosis. Remember, venous stenosis is very, very tough, usually more than coarctation. We started using stents for RV outflow in infants and following this patient 8 years ago. This is an Exopolos. When the surgeon put it in, as you can imagine, the patient became very hypoxic and also had Fowler's pathology. And nowadays, the treatment of choice for infants with Fowler's pathology are not yet suitable for repair. Coarctation, this is a patient where we use an understent here. In this situation, they also very much use Boroker, but it's needed to repair, but these stents do tend to cut very nicely. And if you have a vessel like this one, this is a coarctation here between the parotid and the subclavian, we had no problem with jailing the left subclavian artery, which is big, and we knew that the open cell component would not occlude that vessel. This is a patient with mustards who had an occluded SVC. Again, these are usually quite tough to dilate, and putting in a stent like this is very helpful. If you put an open cell stent here, the chances are that it will pinch at the site where the narrowing is. So you either use a closed cell or a hybrid. And the same with RV outflow pre-stenting. We tend to use the understent XXL because that's the strongest stent that we have. We'll look at the different properties of open cell versus closed cell. They all have different crosses. Here we see how good they are. So on average, the hybrid tends to get the best with the closed flow and the open cell design. And again, as I mentioned, side branches are certainly important. The other thing is in terms of using stents in very small children, I'm sure that with the development of the expandable stents, we will also have hybrid designs to help us with that kind of treatment. So what stent type to use? Think about the type of lesion. Is it a constricted, localized, or is it a long segment? Assess the morphology and the site of lesion. In other words, if you need to do side branch access, bear this in mind, what type of stent to use. And probably for the side branches, the open cell and the hybrid are better. Consider the forces surrounding the stent. In other words, is it behind the sternum and so on. Anticipate the desired shape. So it's very, very important that you think of how it's going to look like at the end. And if it's going to be a complex type of anatomy, an open cell may give you the wrong end result. And obviously take into account what the lesion is. So in conclusion, hybrid stents have numerous advantages in very specific situations. They have a good scaffolding, flexible, accurate placement. They're strong, particularly chromium, cobalt, and minimum shortening. It's about 10% for the understent. The formula hardly shrinks at all. Ideal for coarctation and pulmonary arteries. Benefits from closed and open cell design with less of the downsides of either of the two. And manufacturing technology has opened up the design to infinite number of combinations these days. So anything which is going to make it better for our areas, we need to work with engineers about this. And I think the next step in hybrid stents is to have certainly covered versions, plus or minus drug elution, depending on what the results of drug eluting stents is in clinical practice. Thank you.
Very good, Joe. Because of time constraints and because my colleague to my right, who's given the next lecture, just found out his lecture is only 10 minutes long, we're going to go right to Mark right now, talking about covered stents because abstracts presentations start not too long. So we'll try to keep on time.
Disclosures. What is the problem with bare stents? If you deploy a bare stent in a stenotic lesion, you may have a tear over there that may cause an aneurysm or a bleeding. And worse than that, there may be a tear at the end of the stent, which also over there may cause a bleeding or an aneurysm at the end of the stent, the portion which is shielded by the non-covered stent. Otherwise, there are some problems. Here, an aneurysm after simple balloon dilation. I think that everybody will agree that you don't want to go with a bare stent in this patient. I was told by a few experts in the US that the #1 reason over here for being sued is actually dilation of coarctation, and the major reason is that if there is no covered stent available and there is a major bleed, typically it will end badly for the patient with a very poor outcome if there is a major bleed. Here, complication of a bare stent with an aneurysm right in there. And watch over there what happens in the outflow tract. If it suddenly pops like that, I think most of us will feel a little bit uncomfortable and will be eager to look at the angio, how it looks like. So a lot of these problems can be solved by putting a cover on the stent. And what are the advantages? So the problems with the bare stent are known. If you use a covered stent, well, first of all, any tear or aneurysm within the stent will be covered and the problem will be actually non-existent. And if you're smart enough to take a longer stent than usual and flare it, also the tears at the end of the stent, that problem is being taken care of. And an extra margin is that if you feel very comfortable, you can dilate that stent to almost any size you want to, because you don't care what's going to happen over here as long as the covering will protect you. So a big difference between a bare stent is that you can have an open tear and an aneurysm. Both these problems are taken away with a covered stent. A bare stent will leave you access. A covered stent will give the possibility or the complication of excluding the side vessels, but I'll give a few hints how to get around that. So is the covered stent just a bare stent with a membrane? So it was designed to avoid extravasation, either in a therapeutic way, but people, in Europe where we have the covered stents readily available, more and more we start using it prophylactic, where we avoid open tears, and also where we think that we can get better final results by having more complete dilation. Sometimes you will use a covered stent to explicitly exclude a side opening, either in this situation or an aneurysm. You can make a new vessel. You can get protection from sharp edges. For instance, in the outflow tract, if it's heavily calcified and your pre-balloon will burst on the heavy calcification, sharp calcifications, I would feel very uncomfortable in going in there with a bare stent, because the last thing you want to have is have the balloon explode with a halfly open stent while trying to expand the outflow tract. Also, if you need to do something right next to a pacemaker wire on an RCD wire, the PTFE covering may be of significant help. And also we'll show an example of flow reducers and possibilities during hybrid procedures. The two players we have currently available on the market are the CP stent and the Advanta stent. Both have some specific features. The CP stent comes in what is called the 8-zig system, different lengths. However, extra lengths are available, custom order. What you have to know is that the minimal inner profile is 7 French. So if you put it on a 7 French profile balloon, you have to add about 3 French. So the minimum sheet size for a CCP stent is 10 French. With that, you can deliver a CP stent, for instance, at 16 millimeters without a problem. If you need to go, you can expand the CP stent. The covering will stay intact up till 26 millimeters. The stent itself can be dilated up to 30, But once you go beyond 26, it really becomes a ring, and it becomes very, very short. So that's actually not what it's designed for. If you need to go up those big sizes, better to go for a 10 zig. Again, there is no CE mark, or it's a custom made, but then you can go up for lesions, what the coverage is concerned, up to 36, and also the stent can be dilated up to 36 and still give some threshold. The Advanta, officially on the label it says it should go through a 9 French or an 11 French, depending on which balloon, the 12, 40, the 12 or the 16. In practice, it will go through most 10 French commercially available sheets. Different lengths. Radial strength, there is concern of recall. We just saw it with the case that Eric did show in the session. There are some shoulders on the stent, but I must say that I kind of like those shoulders. They will prevent the stent from sliding off. And if there is a kink in your sheet, I mean, those shoulders will help to unkink. There is another model in the highest sophisticated country in the world, this type of stent, but I must say that I don't have any experience with this model. In our experience with using covered stents, I must say that 80% of the covered stents, we do it the way you all have learned to do it. One balloon, one wire, one sheet, one go, and that's it. However, the more and more complex lesions we have been dealing with, we start to split up the complete procedure into different aspects. For instance, if sheet size is important, you will go for the smallest balloon and just have one type of balloon to deliver the stent, which is important. When delivering the stent, you can go for a long balloon, or sometimes an oversized balloon, that especially if you want to have a flaring. I'll come back to that in a second. You can go for double wire delivery. You can go for sequential opening if you want to reposition the covered stent into a lesion, into a bifurcation. Attention for surrounding, sealing, flaring to seal becomes very important because you want to disobstruct and avoid vortices around the stent. I'll come back to that in a second. Side vessel accessibility, where either you flare or you go for retrograde puncture. And so, last but not least, you go for the high pressure balloon if necessary to still dilate the lesion. So as I said, in 80% of the cases you can do it with one balloon, one wire, one sheet. However, depending on some technical aspects, you may split it up. In our experience, 3 big groups: coarctation, right ventricular outflow tract pre-valve, and then miscellaneous. Here, typical narrow coarctation. You can do that with a simple balloon, but it won't solve the problem of the hypoplasia. If you take a bare balloon, a bare stent, it will work. But I mean, there is an increased risk for an aneurysm or a bleeding over there. A covered stent takes the problem away. At this point, you can choose to further dilate it. If there's going to be a tear, it's going to be there, but you can easily flare that stent into the wall and then contain completely any bleeding that would occur. Can you take the stent all the way up at once? Well, it happened over here in this kind of patient with a very narrow coarctation. It is my gut feeling of not taking it all the way. If there is going to be a tear in this patient, it will occur over there. Now, you can get away with it, and some people will advocate or have a blind belief in covered stents and dilate it all the way up. A year or 2 ago, Ziad did publish a series of his covered stents where in a nearly identical patient, when taking up the stent, he made a tear over there. Now, so that patient then was almost bleeding to death. If you know that this distance easily reaches 40 millimeters and then you want to cover it, you know you're in big trouble. Ziad got away by implanting then the Medtronic tube graft, which needs, however, a 22 French introducer device. I mean, it's huge. Some adapted techniques are required when you start using the covered stents. Go for maximal sealing, double wire, reperforate the membrane. The sealing is important. As I said, if you want to take care of lesions like that, it is smart, I think, to go from healthy tissue to healthy tissue, and actually use the ends of the covered stent just to oppose against the wall. Do not exert any pressure on it, but that way you will seal easily anything you will tear or rupture over there. Also, be aware, and I think the last patient that Eric did show was a very nice example. If you use a bare stent, this is going to be the flow profile. The blood will not find any hindrance or too much hindrance of this. However, if you use a covered stent, and in the patient that Eric was just showing, this covering, I mean the stent was way up, don't forget that this acts as a tube. So the flow profile will be like this. In other words, first of all, you have a longer tube which may be restrictive. Second, you have a vortex over there which can push on the other side of the stent. I'll come back to that in a second. If you, however, you flare, it will take care of both these problems, and you will have the ideal flow profile that you want to have. Here a patient who also had a long covered stent inserted. The stent goes from here till there, so that means that the blood flow can push against this part of the stent. 6 months later, this is what happened, or the patient presented with a stent which was completely infolded. So the message over here is, do not underestimate the importance of flaring, and do not underestimate the power of chronic pulsatile flow. And by the way, that's what the heart is doing. Double wire, where do we need a double wire? Well, if you see a lesion like that where the subclavian comes very, very distal, very, very close to the coarctation, if there is going to be a tear, it's going to be over there. So here it just reflects how short the distance is going to be, and my prejudice would be if there is going to be a tear, it's going to be there. If you want to stent this in safety, my preference now would be to go for a double wire. So what you need, both wires, 2 balloons, stent, and there is some arithmetics to it. If you take a balloon with a 5 French profile and a 5 French profile, and then the CCP stent, which has a profile of about 2 to 3, if you add this up, you don't reach 13, but you will reach 11. Why? Because you will have an oval shape. So this over here may take 13 French, but this over here will be only maybe the distance of a 9 French. So in total, it will fit into an 11 French sheet. And don't forget that the valve of a 10, 11, 12, and 13, 14 French sheet, they all have the same valve, and they all will accommodate a 14 French device. So taking back to the patient, we're ready, inflate slightly the balloon. At that point, we deflated the balloon and pushed the stent as far as we could into the bifurcation, and then further expanded it, and from here then it's a piece of cake to further expand it with high pressure balloons and take it wherever you want to. This picture you saw before, the big problem is that the aneurysm is just opposite to the left subclavian artery. Can also be a pain in the neck. However, if you use, again, the double wire technique, you really can push your stent as far as possible within that bifurcation. Here with then full deployment of a stent. I would have preferred to have a somewhat longer stent, but that day I ran out of the different sizes. But here the job was take away the aneurysm, and that was dealt with that way. Perforated, recrossing the membrane. In this patient, the coarctation is just across the subclavian artery. And so Joe showed an example where he would put a bare stent and leave the side openings over there. Now, the other option is go with a covered stent like this, deploy it, and as you see, we were ready with a 4 French catheter, ready once that the stent was deployed to puncture it retrogradely, dilate it, and we made again anterograde flow across the left subclavian artery. Theoretically, you also can do that with the left carotid artery if you put a sheet over there. I've never done before, but I think technically I feel confident that it would work. What about pre-revalvulation? Again, the case of Lee Benson was very interesting. What happens if you insert a homograft into patients? In our experience, most of the shrinking will occur at the muscular cuff and proximal, but actually it can go anywhere. My goal nowadays is to take a covered stent which will cover the homograft from proximal of the homograft until beyond of the homograft, cover the whole thing. I do deploy the stent in a first step just so that it will oppose the homograft with no intention to dilate at that point. And then in a second step I will dilate and if required add additional stents just to keep the whole thing open. Here an example, a patient with a 13 millimeter homograft. At this point, at one point obviously he did outgrow it. How did we manage? Balloon interrogation, make sure it was done before with CT, but we reconfirmed it during the cath that the coronary arteries were a mile away. Implantation of the covered stent from proximal until distal of the conduit. Make sure everything is well in position and then dilate it 18 millimeter, and finally this is the final picture with a 20 millimeter melody in place. Observe the difference in size. I think it can be appreciated. I'll jump this and go straight for miscellaneous.
Hey, Mark, because the abstract started about 10 minutes ago into the session, so we'll probably need to wrap up unless there's a major point you want to make, because the abstracts are going on in the other 3 rooms right now.
I can stop.
Okay. Thank everyone for your attendance, and hurry to the abstract room.